Okay, welcome to Internal Medicine Grand Rounds today. I'm very happy to introduce our speaker, Dr. Ebrahim Barkoudah, who did his medical school in Damascus, the University of Faculty of Medicine in Damascus, Syria. Then he got an MPH from Harvard School of Public Health. He got a few other degrees, including an MBA just this year from the University of Oxford, remotely in his spare time because he doesn't sleep. And he came to Baystate just last year as the system chief for hospital medicine and the regional chief medical officer, chief quality officer as well, basically running a huge hospital service. He hit the ground running. He's involved in many, many projects, very dynamic speaker, and we're happy to have him here. And today, I'll let him go from here. Ebrahim.
Thank you very much, Dan. Grateful and true privilege to join the Baystate family and be member of this phenomenal team. Thank you for your kind words. I'm going to go ahead and share my screen and start maybe give our audience a little bit of why we're doing hospital medicine, something I'm passionate about, along with the hundreds of faculty and members that we have on hospital medicine. So thank you for joining today. I'm going to focus on my slides and happy to take questions at any time. I have references and a couple humorous joke to soften the content. If you would like to have any access to any of the materials, please let me know. Happy to help. These are my disclosures. I've done work related to clinical research and my past roles at Brigham and Women's Hospital and Mass General. I love to publish. I've done non-compensated consulting around healthcare, specifically the NHS. My greatest disclosure is really how we all of us share that passion for medicine. Bear with me so I can build it up. Our objectives, long list. We will go over the current state of hospital medicine, highlight really what's been successful and what not, and specifically link it to the value-based care, the next phase in the care delivery, the many problems we encounter clinically on the administrative level and anything in between. And I'm going to go a little bit more depth into the modern healthcare delivery around quality and safety. And I would like just to make sure we look into the future. And I will give you a promise that a couple slides from now, I'm going to talk about AI, but I'm going to just shut it down until we get maybe 45 minutes into this presentation. Every time I try to explain what I do, I pull the house MD on anyone in a social context ask me for details. And most of them, they say, oh, you're an infectious disease. And I see Dr. Salvador, Dr. Hustler, and I say, I'm privileged to be one, but I do a little bit different. I'm more on the Lisa, the character in the pink top, a little bit of more administrative and a little bit more clinical. I do not have a cane and I do not drive motorcycles anymore, but you got the reference there. I would like just to zoom a little bit in and bring our team to the midst of it, where the Division of Hospital Medicine under the Department of Medicine is one of the largest hospital medicines in the U.S. 4 campuses, as you all know, over 40,000 discharges, 250,000 encounters annually. A lot of work been done to bring this awesome team together. And I would like just to make sure we put our mission in the middle of it, where we want to provide and we will commit to provide the best care for the inpatient services. The second part is really why hospital medicine. And I really wanted to consult with a friend and I got so many things around hospital medicine. Just type why hospital medicine now, and 30 years probably into this care delivery model, you will see all this talk. But just a second, this is a truly AI generated answer. And really, our work is not about aligning what we think it works on the paper. I really want to dive deeper of that inpatient stay, the journey of a patient coming into hospital and leaving. So I'm going to leave AI for now, but we'll come back. We see that care is where the patients, they come and they leave the hospital better and healthier. And we know we treat everything of the leading causes of death in the US. And I love a care delivery model when we have the patient in the center of it. Even though AI is coming in the digital and the algorithm invading every aspect of every sector, most pictures would show you that we get closer to the patients and feel privileged to touch their lives and be part of it, even for a short period of time. This is the CMS framework where we know that it comes of all aspects. We have equity on the top of it. We have engagement. Hospital medicine more lives in these two words, the worlds of making sure we do the right thing and we focus on our outcomes. And mostly we drive that. But let me just pause a little bit, because this is not how everybody else probably perceive medicine. We know about the unnecessary care, and we know about how much that been under scrutiny with many aspects of the care delivery. We know about the cost of care, and I'm going to go over that. We're spending a lot, and I feel this is also affecting how we see ourselves, our profession as physicians, as caregivers, as someone who would wake up and come every day to the same position to provide the best care. And we really don't want to muck up what we do. We want to hold it up high. I spend a lot of time thinking about it, and I would like just to put in the center of it what would be the 5 domains, the 5 pillars for the care delivery around effectiveness, efficiency, equity, patient center, and most importantly now, the safety. A lot been put in front of us about the best care model, but these are still words. And we need to drive it to the outcomes. We need to drive it to the best care. When you and I need to come to the hospital, we leave better and healthier. We know the landscape is changing. We know hospital medicine needs at least to catch up, if not bypass that, and make sure we get it to what would be a standard of care. I would like just to maybe set the table and share with you. If you're not familiar with this gentleman, he coined "In God We Trust, all other must bring data." This is Ed Deming, probably the icon of quality, not specifically in medicine, but we're going to use a lot of these concepts to bring it to specifically hospital medicine and inpatient care. I would like to take you a little bit of a review, see how could we do hospital medicine better locally, regionally, globally, and really tackle this cost of care and the quality of how we provide the care. Big picture, we do have count of the licensed hospitals in the US. And as you could see, this number over years has been decreasing. And many hospitals might face the same aspect of how they could run an efficient system. And I'm going to bring the physician, I'm going to bring the executive to this conversation. And I also want to bring the patients, because these counts, and I'm going to show you globally, might not be enough to care for our patients. Let's take it a step further. When you talk about how many beds licensed in the US, that number is also decreasing. Maybe it's part of we need to be more efficient. We need to be more diligent of how to deliver the care. We're hovering now around 900,000 beds in the US. We learned it the hard way when we went into COVID operation. More to come, the number will decrease, but there are a couple good news. This is the slide that I would love always to start my conversation about inpatient services. The number of hospitalization in the US been flat numerically, i.e. we've been admitting around 35 million admissions every year. And one of the things that we need to make sure these are all comers. So these are the PDs, the OB, even the electives one. We have 7 million admissions that medically ill, 1 million ICU. And I'm going to take you through a couple slides of can we get it 7 million times right? High quality, no safety signal, get the patient the best outcome they deserve, they're asking for. We need to get it right millions of times, no mistakes. Another aspect of it, 1 out of 13 of us would at least come to the hospital once a year. Let me repeat this. 1 out of 13 annually will come. And as you could see, this number dropped and then picked up. And there are many explanations for this. The science is catching up. We know how to treat diseases outpatients, which is better. But now we need to focus on getting this a little bit under control. Lower is better. What about length of stay? We all know shorter length of stay, when it's right, it's the best. And that number been decreasing in the US. You're going to see this 5-point-something days is the ideal number. It means we are efficient. We are doing something better for the patient. We want them don't spend days in the hospital. We want them to be with their loved one. We want them to be in their homes. We want them to spend the best of time outside the hospital. Let's take it a little bit step further, where now the costs come to it. Right after Second World War II, we've been spending way less than what we've been spending at least before COVID, and now this number start exceeding. This is now in the trillions. And this is only how the hospital operates. I'm going to break it down for you, but $1.2 trillion with the T is a lot to do for only inpatient services. And that really is a testament of how we could also control the cost. An economist asked me, wow, you guys been spending what worth of Google every year on the inpatient services? And I said, not really, maybe more. Google is valued at over $1 trillion, but they're actually assets, they're way less. This is probably all the technology sectors together getting spent to improve lives. And if you look at how we spend it, hospital medicine really lives between inpatient, which is about 30%, and the post-acute. So combined, that's a lot of innovation, a lot of delivery, and most importantly, services. As a sector, we're doing probably the right thing. We employ more in the hospital. We deploy more resources in the hospital. Most of physicians now employed by the hospitals when they do inpatient services. So that model start picking up. But in general, in healthcare, about 40% employee in the US, they work physically within these walls. But the story would not stop there. We know we're spending 18% of our GDP only on healthcare. And remember, now this is about 50% going directly to the inpatient. And we spend more than any nation on earth. And this is indexed per capita, right? If you look at the amount of dollars, we probably spend more than the top 5 combined, because the US has more population than the rest, but that is proportionally higher. Canada's catching up, maybe Germany and France and the UK. They do have their problem. There's no system perfect. Anybody could mesmerize with Europe, but this is a lot of resources going there. Comparing to the globe, and you've probably seen something like this, most care getting spent in the inpatient. The US is still around that 30%, but there are more nations where they focus more on the inpatient. We're doing right. We want to see that gray line getting a little bit closer. That's where the outpatient preventive care taking over the expensive care delivery of the inpatient. Let's take it a step further. How are we doing? We're spending a lot. We employ. We focus on it. We have a lot of innovation. If you look at the ranking of worldwide, what the care delivery would look like, you don't see the US on the top 10. We're not even on the top 20. And these are based on metrics indicating what would be the sustained good of health. Take it a step further. What about how we could deliver care in high quality? You look at the globe, and the US is not even on the top 10. And this is also how you treat disease and keep the population healthy. I don't think we're doing good. You know that. But globally, we spend more than the top couple, but we don't get that value, right? And now we're speaking about value-based care. When you look at the performance, specifically for high-income country, we start making it to the top 10, but that's short-listed, right? So we're number 11 out of 11. We do have many tools to measure it, but when we measure it globally, we need to do better. Gets a little bit more. When you ask any patients about the access to their care, I'm going to go over that, and there will be more talk about the access for the outpatient and the inpatient. The US really would become on the ones that literally 11 out of 11. So you spend more, you do not get access, and your at least perception is different than all the other nations that they monitor their spending. What about the age? And that's really matters, because in the US, we know who needs access to care are the ones needed to have that given complexity of disease management. This has been stable in the US. We do not have an uptick in more disease in childhood or middle age, but we need to do better because our population will age and we need to catch up that faster. Taking it all together, if you look at the outcomes and you look at life expectancy, which is really a surrogate measure of the population, the US is not there. You knew that. Let's take it a step further. What we do about maternal mortality, higher is not better. So this is now the opposite of it, where the US makes it on the top 4. We're not doing well even in a preventive medicine. When you look at the mortality, and again, higher is not better, you need to be on the lower, we really up there. And that's also a surrogate of, do we need to be more on the preventive side than hospital medicine? And the aspect always is, there is more to do outside the hospital and more to do in the hospital. And if you take it as a patient satisfaction, and we need to talk about patient surveys and patient perception of the care and how they feel. Now, this is very interesting that Saudi Arabia is number 1. So we're not even on that list. We're not even in the top 20 or top nation that would really think about the satisfaction. If you ask worldwide what really concerns the patient, they would tell you access. And you're going to hear about this. Access, access, access. I need to have more doctors, more APPs, more facilities. It gets a little bit more different. This is the global worldwide view. if you look at the US, it's the cost of care. So it's maybe access is not there yet, but we know our patients telling us we need to have control of the cost. I do not want to see these bills. Let's take a moment because we live in Massachusetts, and this is per capita. Darker is higher, and you could see where Springfield is. Dover, which is a town down near me in the Eastern Mass, this is per capita income. It's almost five-folds of the Hampden County or Springfield. And that's a surrogate of we need to have more where we need it. And if you look at Massachusetts map in terms of care delivery, the cluster is still around Boston. And the argument is this what the care needs because of the density of the population. We're here. And that's very important for us at Baystate because we need to deliver the best care delivery, pretty much anything outside the 95 ring. And to take it a step further, and if you're familiar with the SHIA, this is a center that is funded by the Commonwealth, but it's non-governmental. It really measures the care, and it's reporting all the outcomes and safety. And we know we're doing good. And I see the quality team and the safety team, and we need to have better understanding of how we could deliver the care inpatient and outpatient. But bear with me, I'm going to walk you through it. This is a slide that I brought with me when we want to see length of stay comparing Baystate Medical Center, our BMC, to the other similar hospitals. We're doing good. More work to be done. That's a trend over time. You've seen any hospitals that above 500 beds, they really need to do better, but we are doing good, but we still have an opportunity. We need to make sure our length of stay here is better, our care delivery is better, our safety and quality where the patient, they need it, and we could serve our population in Western Mass. I'm going to take you a little bit more into New England area where this is the health system ranking per state. And Massachusetts is always in the top three. And we always have this chase between Hawaii and Rhode Island. And 22, we were number two, now we're number one. But we need to do better locally. This is more the state globally, and this is how the health system is ranked, but more to come. When it comes to the quality of care and how adults in the US, they say this was excellent, it's about 50%. And we need to do better to serve our patients and focus on the cost. Now, I'm going to zoom in a little bit in and then zoom out, because in the United States, the bed per day cost is about $2,600. And Massachusetts is always on the higher end, given the Commonwealth labor and innovation that we've been leading. But if you could see here, there are states that they are able to deliver probably as good model as us and with a lower cost. And if you look at the American Hospital Association density of facility, they're East and West Coasters. And we're right here, and we're privileged to be closer to everyone, but our counts of hospital should be enough to deliver the best care. The cost still a problem. You always see the Northeast dark into the density of how much we need to spend for hospital day bed. Connecticut and Massachusetts probably are comparable, but Connecticut usually higher along with New York. I will get to that a little bit more. This is probably one of the best slides to summarize how we look at the hospitalization science. This is the HCUP, which is the healthcare cost and utilization project. And as you could see, the Northeast probably has less than 6% or 7% of the population. And the New England really has a higher stay. So we tend to admit more. Put it all together, and if you look at the U.S. At least population rates and admission, we're doing good in New England. Our cost is still higher, but our length of stay is comparable. And that's also important because we're not comparing ourselves to a hospital on the West Coast. We need locally to see how Massachusetts would look like and how we could deliver that model. I spend a little bit more time thinking about what would be a framework to define that implementation. And it's always would come down to the 5 pillars: effectiveness, safety, and how that would look like in terms of building a framework to deliver that continuous improvement. Now, I want to just show you one slide that it's really about the safety signal and how we could do better collectively. If you're familiar with the Harvard Medical Practice Study, it's not unique to Harvard. Now it's Massachusetts, and I will share more details with you. But 1 out of 4 patients, they come to the hospital and they have an adverse event. And that's a global. That is not just unique to us. And we need to do better. Hospital medicine would be in the center of it, and we need to get that guidance from the quality and safety department. We're responsible for death because of errors, and I'm going to go over that for the inpatient and outpatient. But 1 out of 4, 1 out of 13 will get admitted every year. 1 out of 4 of them will have these outcomes that we thought at least it could be preventable. Quality matters. Quality in the inpatient care delivery, especially after how much we're investing and spending, matters to us, to our patients, and how we could do the best model. This is how at least Kaiser sees their delivery model. I like my checks and I say, yes, hospital medicine is around how we could coordinate care, how we connected with technology, how we apply the evidence-based medicine and have the implementation science. Preventive care is not within hospital medicine, but we need to have culturally responsive care delivery. And put it all in context, the characteristics of quality in healthcare would keep these 6 pillars in the core of it. And we need to, because we need to provide safe care and we need to be equitable. And that matters more to Western Mass than Eastern Mass. And hospital medicine will check off all these items. I spend a little bit more to think about how you could put that in a quality improvement research framework and take it together with the implementation science. And we're still trying to rethink about the system redesign and how you could together put it in the operational principles and go and tell the senior leadership how we could do better together. Hospital medicine is not new. And you've seen slides like this where we know we probably started disorganized, but that movement of hospital medicine picked up. And this is published, but we know probably we're exceeding the 70,000 what's known as hospitalists. And I would like to make sure we put the quality of it in the center of what we do. Are we doing better as a system? This is no other than our own Dr. Lidenhauer, and this is still 07, and more to come about what the model would look like. But hospitals, they are having probably better outcome in terms of length of stay, but we're not able to curb mortality comparing to what was the old system. Now, the old system of a physician, she or he or they go to their clinic and then they come in around. I don't think that is lasting anymore. So I would like to see more of how we could drive the care to better outcomes, to less cost, and hopefully patient will spend less among us. And I'm going to just bring you maybe a little bit of examples of how we see ourselves responsible and accountable. This is a ARC, the Agency for Healthcare Quality diagram, which really showing that, hey, where are the failures in VTE prophylaxis? And it's mostly us. It's mostly hospitalists, and we could do better, and we need to own it, and we need to step up. Well, if you look at really how the hospital acquired one, the other side of it, not the prevention, hospitalists also are part of it, and we are maybe not the bottlenecks. Would probably be the solution. And if you take it into a little bit more of implementation, this is work by Dr. Menard over San Diego, UC San Diego. You can get a better prevention of hospital-acquired VTE up to 100% if you deploy the right model of hospital medicine. More to come. I love to see the 100%. I think sustaining it is another goal, but we need to get to a model where our outcomes getting to the 100%. Barriers to health, we need to perform better. We need to go through these layers of how the healthcare delivery will deploy knowledge, will disseminate the best practices. And if you try to put it in buckets, I always thought about patient-centered approach. We need to bring us, the individuals, really how our practice and environment, and put it into that macro level of organizational goals, because we cannot go far until we have the team we need. I'm going to give you my own examples. I thought about taking that clinical trials model and think about how we could do better at the bedside. We went into the clinical trials. This is probably better for the patient. Guidelines improved to think about how the extended VTE prophylaxis post-hospitalization would occur. We laid it over the VTE dashboard, but we were not successful. The dissemination of specifically that VTE prophylaxis did not really adjust to what we would think the better for the patient. Is the problem we're focused? Are we really just thinking about it as we need just to hone in a specific disease and we could do better? The answer is maybe yes, maybe no. This is one of my favorite studies that have been published in the last couple of years, where if you hone in acute heart failure and you try to say what would be the best model for patients to prevent their readmission, the coach trial investigator said, oh, we can do that and we can do it right. So if you look at the 30-day hospitalization for CV causes or for the heart failure, lower is better. The CI is not crossing the 1. So maybe mortality is a high threshold to curb, but the heart failure specialists, they did it. They said, okay, well, we can reduce that. But there's a little bit of segue there because it's still closer to 1. So this is not a slam dunk. You could deploy resources to prevent the admission on the top of the best medical therapy, but you're still hovering over the 1 here, which makes this a little bit concerning. Different aspect, different group. This is the Yale group, went into the same approach, and they said, okay, we cannot even alter mortality. So even for the heart failure, you can get 1 positive trial, 1 neutral or negative trial. And is that the right thing to do? This is different group, different country. This is Jacques Danze over Switzerland. And he put this infrastructure to prevent readmission post-hospitalizations. And it turns out that it's neutral. It's not better than the standard of care. So when we think about this readmission science, maybe we're not there yet. I'm going to take it a step further when we're going to say, okay, is this really related to be perfect? Are we really honing in a disease? And we need to zoom out and think about it. One of the trials that I think it's probably a nuance, this is Dr. Escobar over Casa Permanente, where the automation of change in the physiologic status during hospitalization will prevent death. This is us monitoring the patient with similar AI tool. And the answer is, whoa, we can reduce mortality. We can reduce 30-day mortality. This is really rare to happen now, given how much the therapies they're catching up. But there is a glimpse of hope that we can do better during hospitalizations. And if you try to put it together as innovation and dissemination of guidelines, there's always what is known as the valley of death, where the innovation will not get the implementation. And maybe we need to think about it as we can curb mortality, but we should be focusing more on the hospitalizations rather than the disease entities. What about our patients? If you're familiar with the patient experience, it looks like this. And the more you see of the smiley faces, the better. We need more of patient experience. This is one of the intersection between the readmission. And I'm going to argue that 15 to 17% readmission, and this is Massachusetts data, probably something we need to curb together. The top of the list is always heart failure. I've shown a little bit of thoughts that this might not be something we can curb, and we need to do more. I'm going to come back to the safety. This is, again, the Harvard Medical Practice Study 1. This is 91. And if you're familiar with this, you know within the inpatient, we need to do better in terms of preventing these safety events. Newer generation, this is Dr. David Bates from the Brigham. If you've seen the new Harvard Medical Practice study, you know that 1 out of 4 still having adverse events. And that is not okay. We need to agree that's not okay. Not any other industry would have that failure rate. And for the inpatient, we need to get it better. I've shown you some of these slides, but medical errors is about 200,000 deaths. That is sad, but that's the truth, and we need to face it. And if you think about it, probably 50% occurs in the inpatient. And it's the third cause of death. If you take that number, that is 2 Boeing 757 falling off the sky every day. And that's not okay. We need to do better, inpatient and outpatient, and we need to deliver the best care. This is how the CMS sees it, and it's really the center of the care delivery around now 8 pillars. It's really about getting the patient in the center of it. Take it a step further now, the value-based care. This is the group over University of Pennsylvania. The Penn folks, they're really trying to put it into context, but if you put it as category, higher is better, higher is less about the payment and more about the outcomes. We still live between category 2 and 3. We've been having that departure from fee to services without a link to quality. We're great in reporting quality outcomes for the inpatient. We need to do better and transition ourselves to what needs to be a comprehensive care, both for the inpatient and outpatient. We're going to see this, and I hope we're going to see it at least in our lifetime. When it comes to the framework of CMS and where the hospitalists sit, you see us right in the middle of this, along with specialists and PCP. So the model is not centric only for the hospital medicine. It needs to have more infrastructure, more training. One of my favorite examples for the innovation of how hospital medicine could be innovative came out the University of Michigan, and this is Sanjay Sain, that we could train hospitalists as a specialist through this SHARP program to do better and have this crossover science and deliver the best care. Now, this is University of Michigan, Ann Arbor. I'm going to bring it a little bit locally. You're familiar probably with this slide more than me. This is the oath model, and this is the access intertwine of the best care delivery model. And Dr. Onestein said, well, this is how we see the access globally. And I live right there, where we need to do better in transition of care. We need to do better in the cost. This is the lifetime of the patient. Patients should have more outside that smaller ring of hospitalizations, but we're still spending 50% of our resources for that very tiny small ring. So I just want to spend a little bit more to say, this is this should not be 50%. We need to do better. Zooming out a little bit, Dr. Berwick from the IHI told us about the triple aim. And the goal here is really to bring everything together where the integration between the cost and the care would come together. A little bit more thoughtful input from Bates's group about how we could do better in equity in the digital age. And now I'm going to start dancing around the AI. And this is not a generative AI. This is not a text generative aspect. This is more about how we could do better when we could flag the safety event before it happens and be able to deliver an effective and cost-cautious model. Take it a step further. This is Karthik from the AMA with Teja Gandhi now at Preskeni, that we need to also put that safety and equity and have that model merged. Otherwise, we're going to focus more on the cost and not the patient per se. I'm going to now dig a little bit, as I promised at the 44 minutes, that AI is coming, and AI for the inpatient will be between clinical operation to value-based services. And you've probably seen this publication in NEJM, but the whole goal here is not just to say, check off, we're going to do it. There will be a lot of analytics in the background. We're thrilled and happy at Baystate. If you want to take a look at the quality and safety and operational efficiency within our system, I will give you a quick tour, but we need to do more. We need to have one click a button where we could see our system and know how to deliver the model. And AI as a model would really be intertwined between the hospital and the outpatient. And we need to do better in integration rather than say, this is not our problem. And there will be many talks about it in the future. To bring it all together, this is how the care delivery model occurred almost a century ago. This is where we started. We bring over what would be operational efficiency and strategy to monitor to get to our North Star, where we can have an algorithm, and I'm not talking about a robot treating our patients. We need to have more resources that we use it to guide us the best care. We need to have more of that value, which is quality over cost. We need to have better numerator, the quality, less cost, denominator, and put it all together where that AI would be helpful to us. I'm going to summarize a couple of thoughts. Our path as hospital medicine is not going to be linear, is not going to be direct. We need to collaborate across disciplines. Heart failure, the neurologist. Our model here is more comprehensive. The 80% of our patient care by hospital medicine at BMC, and across our network, it's larger than what you could see probably anywhere else. Quality and safety of the care delivery will be in the center of it. And I'm going to hone in really about care, cost, and outcome. Value-based care. This is how we will be paid. This is how we should think about our model as a whole. Hospital medicine is a center of modern healthcare, and I hope I've been able to convince you or bring some data to shed light about what we do during hospitalizations. We have a lot of challenges, but our patient-focused, data-driven, and hopefully technology-based will get better. But we need to get to value-based services faster, better for you and me, and everybody would come to the hospital to be treated and leave safe and not have any risk of facing safety outcomes. So with this, I would conclude and take your questions. Thank you very much for having me. Dan, back to you.
Thank you very much, Ebrahim. That was a very nice overview and sort of game plan, if you will, of hospital medicine and quality and where we should be going in the future. That was great. We have any questions? I'm going to ask one question to start with. You showed that the cost was more expensive. Medical care was more expensive on the coast in certain areas. Does that directly correlate with the number of providers and specialists?
So, Dan, this is excellent question. So it's really multifactorial and multifaceted. It's the labor cost, it's the cost of living, more technology, but we're getting maybe a little bit better outcomes. It's hard to measure because the crossover, and especially when you live in a place where probably patients are crossing over state line, but it's true model to say this is maybe the cost of doing business in states with higher income.
Thanks. Dr. Broder has a question. Thanks, Marty. Is Baystate developing a hospital at home program?
That would be music to my ears. I do not know the answer. I know we're thinking about the best model and platform. Hospital at home or home hospital is probably the most innovative approach where we can keep the ones they do not need to come to the hospital there. There are many publications around the efficiency and better cost. Dr. Broder, I'm not sure how much we could do that in Western Mass, but I would love to see it happening yesterday. I'm not sure where we are. I will take this question to the senior leadership.
Question in the chat, Dr. Tewari, do you envision AI leading to lowering of total cost of care?
Vishal, this is likely the answer to be yes. So they're going to be hard to run a clinical trials in a conceptual way where we have hospitals running it on AI or not. We know that AI has potential, and I would like to be a little bit more cautious. And again, we've been dealing with AI for the past maybe 2 decades. So the AI is running in our platform for utilization management, for data analytics, for how you plan budgeted programs. To get the AI and have it in the hospital the way, at least that earlier study from Casa Permanente, I think that would be a dream. And this is the decision support during hospitalizations, but we need to do better. We need to monitor the patient 24/7. And it's going to be up to you and me and us to say, I agree that AI is picking a safety signal or is picking a trend that the patient is declining and we need to do something about it. More to come, but I see potential and we need to be better of how we implement. And I hope that would come very soon. I see a question from Dr. Lindenhauer, and I'm going to read it, Dan, if you're okay with this. How much higher costs for the U.S. healthcare are a function of higher prices, charges, salaries? I suspect both, and you're right on. And Peter, I engaged with conversation at the NHS where, and this is kind of more stepping back. And as Dan said, I've been involved in this degree where I love to spend a little bit more time if I can afford it in the UK. Their salaries in the UK lower. They're having major crises in the NHS where their doctors, they're not wanted to even stay in the UK, and they want to go somewhere else because the US and the glory would always put a little bit of different reality. But the answer is it's multifaceted. So our salaries, they're higher. We driving probably the biggest innovation movement in the world. And these are words from Dr. Robert Califf, the FDA commissioner, that probably we do not need more acceleration and innovation. We need to know how to implement what we already invented. And that's probably right. We spend more. We do have a lot of waste, and this is not probably news. We estimated, and this is Ashish Jha, Dr. Jha's lab, that probably between 20 to 30% is administrative cost. But it's really multifaceted. The one question, the opposite of it, where do we really afford it to keep going this way? The answer is probably not, because we're driving the cost globally also. And we want to make sure that that's also understandably better. Dr. Salvador, United Hospital Medicine physicians caring for hospitalized patients is now the norm. So if we're going to measure the quality and safety performance, compare hospital medicine programs at other hospitals, what are the most important measures that we should use? So I'm going to break it down into the quality and safety. Quality is how we do evidence-based medicine. So that would be disease-specific, time to antibiotics for pneumonia, how we could do better in disease management like heart failure, and are we on a quad therapy or not. So these are more standardized. The comparison of the quality is going to be much harder going forward. And I brought Dr. Lindenhauer study where it's probably, we had a model that we called it the standard of care, so we could do comparison and adjustment. I think we need to take it a little bit more to the next level, where the compliance should be 100% for quality. The safety is measured in multiple aspects, but as you all could see, and Dr. Salvador been looking over my shoulder in how we can design the quality and safety dashboard at Baystate, which you will see, and really put that safety in the middle of it, the CAUTI, the CLEPSI, the FOLS, the VTE. So we need to measure it and we need to compare it. It's going to be harder because the model of hospital medicine been scaled up everywhere else, and now home hospital is comparing to hospital medicine. I think statewide we need to see it better, and I'm always look up to see the SHIA work, where at least in the Commonwealth here we're able to pinpoint these events and for learning purposes say we could do better. And 0 is what we're aiming for in terms of safety. Historic quality comparison is going to be harder because our patients really taking notes. And if someone would say, well, how could we do this better? I would like to reintroduce the collaboration with the specialist. So this is very important for us in hospital medicine to know this is not one person show. The heart failure went into that zone of let's prevent readmission, and the data is probably not what we wish to see. Probably hospital medicine could come into it and help because more we're in the system rather than disease management. I would love, as a final thought, to see a scorecard for each clinician where it's not going to be the punitive, but for us to see our own outcomes like the surgeons. And 0 should be the case for VTE. 100% should be the prophylaxis for VTE. There will be outcomes that we're going to try to curb it together, which is the readmission. But the more we invest in the comparison of the group and state, and hopefully one scorecard where our patient might not be able to say, I would like to come and see Dr. Salvador during hospitalizations, or I'm going to call on Dr. Nat, But globally as a group, we should be doing better and help each other to curb the safety aspect and build it on quality.
I think Dr. Salvador might have some little information about the hospital at home program. Doug, would you be willing to comment on that?
Sure. Ebrahim, great talk. Thanks for reviewing all of that literature for us. Marty, Andy has really charged Addie Seiler in her role as Chief Clinical Integration for the health system to evaluate with a team of people that's multidisciplinary all of the potential options and capabilities for monitoring patients at home. And I think that ranges from giving people a scale, when they have heart failure, to weigh themselves on a daily basis, to do remote monitoring. We have some much more sophisticated home monitoring out of our heart failure clinic. We do some monitoring at home for different diseases in our home health program, and hospital medicine has been at the center of that with one of the innovative programs for early COVID discharge during the pandemic. SIVA was key to making that happen, and so were all of you in choosing patients that met inclusion for that. And I think where she's at is looking at the entire continuum from giving someone a scale to hospital at home. We have investments and capabilities in some simple and some sophisticated home monitoring, and we have not yet been able to make that investment into a hospital at home. I think she's looked at some vendor partners that can do that with us and maybe bring capital along to help us pay for it and jump in. Because it is quite capital intensive to start bringing all those services into people's home in a coordinated way for multiple patients in a broad geography, as Ebrahim suggested. So we're not yet in it. I think that's probably in part due to the financial losses of the last 2 years of the hospital, and we're really looking to have a portfolio across that whole continuum. And we will get into hospital home. We've not yet, and it's going to be really led by Addie and a multidisciplinary team that she's got looking at this.
What a great time to be in medicine, and what a great family to join. And thank you for allowing me to be part of this family.
Happy to have you. That was a great talk. The talk will be posted on YouTube if anyone else wants, if you want to see it again. I'm sure we'll be getting many, many hits. And thanks for giving a great presentation.
Thank you.